Do we know people are on? Should we begin? Gonna get started.
Folks are joining quickly.
Okay, let me know when it looks like there's a good amount that I can see participants coming. Very good. Sorry, everybody. No, sorry. There we go. Okay, can everybody see my screen? Thank you, everybody, for joining. I appreciate everybody being here on a Sunday morning. A special shout out to anybody from the West Coast who woke up early to be here on a Sunday morning. We are representatives of the AAPOS Pediatric Uveitis Committee, and we're talking to you today about red flags in pediatric uveitis. We'll be covering masquerade syndromes and other challenging cases you don't want to miss. I have no financial interest to disclose. Our faculty today includes Dr. Gangwani from Boston Children's, Dr. Eldari from Duke Eye Center, Dr. Lamatina from Boston University, Dr. Utz from Cincinnati Children's, Dr. Stahl from Children's Mercy in Kansas City, and myself from Children's Hospital of Philadelphia. We'll be talking about, pardon?
Your screen isn't being shared, just so you know.
It's not shared?
No.
Try that again. Sorry, everybody. And let's go to the okay. How about now?
Good.
Good. Okay. Let me move this out of the way. Sorry. Okay. So we were talking about red flags in pediatric uveitis, and this was our faculty, our lovely pictures. And moving on. So we are going to talk about masquerade syndromes. I'll give an introduction to the differential, which includes both malignant and benign causes. Then we'll have a conversation with Dr. Eldari about patients with uveitis and optic nerve swelling and when those patients need more of a neurological workup. We'll have a section on checkpoint inhibitors because they are an emerging medication that's being used more commonly for treatment of tumors, and they're known to cause uveitis. We'll review that. And because we're still in this pandemic, we have a few facts to talk about with COVID. So I'll begin with discussing the differential form, the malignant masquerades, which most importantly include diffuse infiltrating retinoblastoma, leukemia, lymphoma, and medullary epithelioma. Dr. Stahl will be talking more about diffuse infiltrating retinoblastoma with a case representation, but obviously it's an important diagnosis to keep on your differential because prompt diagnosis can be life-saving. Lymphoma more typically presents in patients age 50 to 60, but it has been reported in children as young as 15. Leukemia, there'll be a case presented by Dr. Utz later, but I just want to mention that the eye is like the central nervous system. It's considered a pharmacological sanctuary, so it's often a site of leukemic extramedullary relapse. So a patient with a history of leukemia who now has uveitis needs documentation or proof that uveitis is not leukemic in origin, but it also can be the site of primary presentation. When a patient has leukemia or retinoblastoma and they present with a hypopyon, it's important to recognize that it could be a pseudohypopyon And a pseudohypopion would more likely have a shaggy appearance. It might not be layering like a normal hypopion. It might have elements that are free floating, as you can see in this picture, rather than a traditional layering hypopion. Medulloepithelioma is a tumor of the ciliary body, and it's a tricky one because we don't see the ciliary body. We more often see the side effects of the mass effect of a tumor on the adjacent ocular structures. So that may present as a cataract, it may present as uveitis, it may be correctopia or an iris mass. It's just important to keep on your differential. Moving on to the benign masquerades, we'll talk about JXG. There's Langerhans cell histiocytosis and some retinal causes like retinal degeneration and Coats disease, which we'll hear more from later, as well as chronic retinal detachment and endophthalmitis. JXG is the most common, JXG most commonly affects children under age of 2 and presents as a tan papules along the skin. The eye is the most common extracutaneous site of involvement, and the iris is most commonly involved. If you see a child with an iris that has a tan lesion or mass, JXG is top of your differential, but you need to look carefully at the skin to see if there are any skin lesions. If there is a skin lesion, that requires a biopsy to make a histopathological confirmation of the diagnosis. If there are no skin lesions, then a fine needle aspiration would need to be performed to confirm the diagnosis. And of course, JXG is most famously known for being a cause of spontaneous hyphema. In my opinion, a very young child with symptomatic uveitis is in itself a red flag. We do have young patients who have uveitis, but typically those are patients with JIA. And we know that patients with JIA classically have no uveitis symptoms. So if you have a child less than 2 years of age who has red eye, light sensitivity, and you've confirmed that there's uveitis, I would be very suspicious that this is from an alternate cause and maybe a masquerade. Look very carefully for JXG skin lesions, consider an exam under anesthesia to take a closer look, and consider an ultrasound. The retinal degenerations can have features of uveitis like anterior chamber cell, although vitreous cell is more common, and they also have cystoid macular edema. We see this in retinitis pigmentosa, Leber's, Stargardt's, X-linked retinoschisis. These are some slides of a patient that came to Children's Hospital for a second opinion. They saw my colleague, Dr. Priyanka Kumar. They had been treated for vitritis that was not properly resolving with topical medications, and subtenon's Kenalog was being offered. There was concern that an OCT had shown cystoid macular edema and an epiretinal membrane. But when we look at this OCT, there is loss of the normal retinal laminations. So yes, the retina is thickened, yes, there's CME, but when we compare that with a patient with CME and uveitis, you see it looks different. In the uveitis patient, you can see these retinal laminations. There are, pretty impressive cystoid spaces, but the retinal layering is still preserved where you don't see it in this patient. And this patient was confirmed to have an enhanced S-cone deficiency. Here's their epiretinal membrane compared to an epiretinal membrane in a patient with uveitis. Again, you can see the preservation of the retinal laminations, but it's lost here. This patient's vision was much worse than what would have been expected for the vitritis, and that was the big clue. So how do you recognize a masquerade? Practice with a questioning attitude. Is the lab workup complete? Make sure to have a CBC to screen for any leukemia. Does the vision make sense with the clinical exam? And always consider other testing, OCTs, ERGs, and ultrasounds. Next, we'll move on to Dr. Stahl to talk about a case of diffuse infiltrating retinoblastoma.
Thanks, Stephanie. I'm Erin Stahl from Kansas City. I do have a few financial disclosures which are not relevant to this talk. As far as our case today, we have a 6-year-old female who presented to the ER with a 1-week history of eye redness. She reported a decline in vision for 1 week. The parents also noted that the eye looked a little bit funny. So at that ER visit, vision was 20/20 in the right eye and 2100 in the left eye. Of note, the pressure was normal in the right eye and 45 in the left eye with eye care. And then the right eye was normal. And then we're going to go into the exam on the left eye. So these are obviously photos from clinic a few days later. But there was 1+ diffuse injection in that left eye. The cornea was clear with no KP. The AC showed 3+ clumpy cell with a 2 mm hypopion. And you can see that that cell, which is notable that we could photograph it, is of varying sizes and is clumpy. Those are big cells. Go ahead. And then these are RetCam images. You can see kind of a normal clear RetCam image, which is not that clear in the right eye. And then just a little bit of fogginess in the left eye. And just peeking down below, you can see a little bit of something else too. The optic nerve's just a little bit of asymmetry because of the pressure. So looking further down in that left eye, you can see this fluffy white inferior mass. Go ahead.
Sorry.
It's okay. So it's interesting that this patient was seen by one of our residents in the ED, and reading her note, she was really accurate on this differential. So she went through a number of different things. This patient actually ended up getting an MR that night, which is impressive. She did a B scan. She did a number of different things, and then she was smart enough to book them the next day because our ocular oncologist was in clinic and I was in clinic as well in uveitis. And so she put this patient in both of our clinics the following day. I'm just going to keep kind of talking about it while Steph works on the slides here.
I'm so sorry. I don't know why it all of a sudden stopped and it's just going crazy.
It's okay, but I think the kind of relevant pictures have already been shown. So the following day, I saw this patient with our ocular oncologist in clinic, and she looked at her and said, "This can't be RB." She said, "This is a 6-year-old. This doesn't look like it." And I pretty much sat there and I was like, "Well, this isn't uveitis either." So, you know, after some discussion with the family and looking at the MRI, which you haven't seen that image yet, but there is a mass on the MRI. We sent them to Philadelphia. And so that patient, you know, was diagnosed with diffuse infiltrating RB. And Dr. Shields initiated local and systemic treatment on this patient. And she's done amazingly well, you know, despite, you know, the tumor load she had in her eye. She's had cataract surgery and her vision's now 20/30, and she's had no evidence of disease for almost a year. So do you want to wait and talk about, I can't.
Somehow the talk we're on just is not in my, I am so sorry.
That's okay.
It is just missing from, I'm going to pull up the, let me go back to the Dropbox and.
So I have my slides in front of me. I can't share them, I don't think, but at least I can speak off of them. So just to finish the case outcome, this was group E, retinoblastoma of the left eye. Obviously, we controlled the pressure topically. She had all sorts of treatment with Dr. Shields. And obviously, like I said before, is doing well. So as far as key points for this diffuse infiltrative retinoblastoma, there's vitreous cell, often a pseudohypopion, and increased IOP. As far as initial working diagnosis on our list and sort of the differential would be RB, and then uveitis, toxocara, endophthalmitis, trauma, and coats. Of note for this condition, these kids may be older. The average presentation in a article I referenced was 5.7 years. 92% of those kids have unilateral disease, and these account for less than 2% of all retinoblastoma cases. And of note, there's also a lack of calcifications. So sometimes we're looking for those calcifications on the our diagnostic imaging, and we don't see them in this type of RB.
I'm sharing now, Dr. Davidson. I was able to pull up the presentation. Does that work?
That is great. Yes, go for that.
So this is pretty much the only thing we haven't gone through right here, which is, yeah, the MRI with the mass, and then go ahead and show the imaging, the next one, just showing the B scan and the UBM. So kind of in a circle, but that's diffuse infiltrating RB. I'll pass it on.
Yeah, next, thank you, Dr. Stahl, and I'm terribly sorry. Thank you, Dr. Utz. You are next to talk about your case, and continue to share your screen, please.
Okay, as long as it keeps going. Just got to run with it. All right, I'm Ginny Utz. I'm a pediatric ophthalmologist at Cincinnati Children's Hospital. I have no financial interests to disclose. So I have a case of a 3-year-old Amish girl who presented to the emergency room with eyelid swelling, initially diagnosed with a chalazion, and she presented to ophthalmology 1 month later. Her past medical history, family history, and review systems were all negative. She's found to have tannish masses on the right iris and initially thought to be consistent with juvenile xanthogranuloma. However, in the setting of worsening swelling of the left eyelid, which evolved to a palpable mass, she was transferred over to tertiary care center for further workup. And as you can see in this image, the iris has really lost a lot of its normal crypts and contour. You can see some infiltration, and then the glaring is blood mixed with what looks like white blood cells. And the differential diagnosis, at least broadly, is leukemia, juvenile xanthogranulomatosis, retinoblastoma, ciliary body medulloepithelioma, Langerhans cell histiocytosis, and if you're really creative, I guess you could say multifocal amelanotic melanoma, but just to keep the differential broad. And so a biopsy was obtained of the eyelid lesion, and a CBC revealed pancytopenia with increased blasts. And this is a representative image demonstrating myeloid sarcoma, which basically is an extramedullary manifestation of disease and of the orbital tumor. It's also seen in some textbooks as a chloroma because it's green, because of the myeloperoxidase staining in some of the tumors. So this child had acute myelogenous leukemia and currently being treated with systemic chemotherapy. The iris masses have started to involute, and Dr. Davidson was actually managing this patient, and they being very careful about the intraocular pressure in the setting of potentially necrotic cells or tissue. But the IOP has been monitored carefully and treated with topical IOP lowering medications. So anterior segment manifestations of leukemia include the pseudohypopion, similar to what you saw with Dr. Stahl's case, with it just looks atypical, but in this setting it's creamy white with shifting of the leukemic cells with head position. You may see pink or layered appearance as an R patient with a hemorrhage in the leukemic cells. And really the important manifestation is, these nodular elevations of the iris, or it can look diffusely thickened, kind of that loss of the iris crypts. And then the TM can be infiltrated as well, and that can lead to elevated intraocular pressure. In terms of primary posterior segment manifestations, you can see primary infiltration of the choroid and retina. Vitritis is very rare, but if the leukemic cells break through the internal limiting membrane, you may see that. And then, of course, the medical emergency here is leukemic infiltration of the optic nerve. That's a full court press emergency. In terms of secondary posterior segment manifestations, you'll see signs associated with the pancytopenia, intraretinal hemorrhages, Roth spots. Occasionally, you'll see microaneurysms, peripheral neovascularization, exudative retinal detachment and when there's choroidal involvement. And of course, you always have to be on the lookout for opportunistic infections. And then just a word on juvenile xanthogranuloma in terms of kind of how to differentiate. This is a non-Langerhans cell systemic histiocytosis with usually an early presentation within the first 2 years of life. The key thing is the skin. Usually involves raised reddish yellow papules. They're kind of dome-shaped. And as Dr. Davidson pointed out, the nodules tend to bleed. And, the board question is spontaneous hyphema. Maybe something that you would see, and then the choroid can also be involved. This is another example from Dr. Levin, and you can see that the iris is infiltrated and there's a large hemorrhage. And then finally, skin, manifestations. They can be yellowish to tannish to reddish, and at different stages of involution. And then here's the famous Tootin giant cell, the histiocytes that have come together with kind of a lipid border here. So the take-home red flags for this case are atypical hypopyon, shifts with the movement of the eye associated with blood. Look at the iris for infiltrative disease. Choose evaluation. Close evaluation of the retina, including the periphery. Ultrasound may be helpful. Ask about AML or ALL, as it is a sanctuary site. And then, of course, look for skin lesions. So thank you. And we will move on to the next speaker, Dr. Gangwani.
Thank you so much, Ginny and Stephanie, for organizing this webinar. I have no financial disclosures. Can we go to the next slide, please? And next. Okay, so we have a 9-year-old girl who presents with difficulty reading. So it seems she has dropped in her reading level in the past year. She saw somebody locally who gave her glasses, which don't seem to help. So the parents have noticed she has been really tilting and turning her head to see from the sides. And she has also been complaining of floaters, intermittent headaches, and nausea since past 1 to 2 months. Review of systems is otherwise unremarkable. She cannot recollect any specific illness before all this started. Of past ocular history, family history is otherwise non-contributory. Next, please. So on her exam, her visual acuity was 2150 in the right eye, 2125 in the left eye. She has really mild hyperopic astigmatism. Intraocular pressure looks good. She is 0/8 on Ishihara color vision test. Rest of her anterior segment exam looks unremarkable, no cells in flare at all, but she did have 2+ vitritis in both of her eyes. Next, please. So we confirmed the color vision deficiency with HRR, no strabismus, nystagmus, no APD, full motility, but her eccentric viewing is obvious when she's doing her vision testing. So you can see her optic nerves, they look really nice and healthy, 0.3 cup to disc ratio. Blood vessels look okay, but look at that macula, it looks little yellowish orange, what we call the beaten bronze appearance. And then there's that little white lesion superiorly along the superior arcade in that left eye with surrounding pigmentation. Next, please. And then there were 2 additional chorioretinal spots in that left eye around 4 o'clock meridian in the far periphery. Next, please. So she did have these autofluorescent spots with a sharp demarcation margin around that optic disc and macula in like what we felt was like a wreath-like pattern. Next, please. We did her OCTs and we found those deposits in the outer layer right at the level of that RPE, a little more in the right than the left eye, as you can see here. Next, please. Her visual fields showed a central scotoma in both her eyes. Next, please. We even did her fluorescent. You can see there was like an early punctate staining initially in the early phase, again in that wreath-like pattern around the disc and the macula, and then there was some late staining in the periphery, as you can see at the blood vessels in the far nasal and temporal periphery there. Next, please. So we sent out her entire uveitis panel. The only thing that came positive was Lyme IgG, but IgM was negative. She had low positive titers of ANA, but everything else looked okay, including tuberculosis, syphilis, sarcoidosis, toxoplasmosis, everything else looked okay. Next, please. So given her significant vitritis and the fundus findings, as you saw, we thought her findings were most likely consistent with Mute's multiple evanescent white dot syndrome. Next, please. We all know it's a self-limiting condition, so we thought let's wait onto it. But then given that she was not treated for Lyme in the past, we did start her on oral doxycycline and decided to monitor closely. I bring her in 2 weeks, and then there's a drop in her vision, 2200 in the right, 2150 in the left. So I get a bit worried. So I thought, okay, maybe it's an inflammatory condition. We decided to give her some pulse steroids for 3 days and put her on oral PED, 1 milligram per kg with a 1-week taper for total of a month. Next, please. I bring her back again in 4 weeks. She has finished her taper. Thankfully, her vitritis does look better. It's 1+ this time, but then no improvement in her vision. So I repeat all her testing again. Everything looks exactly stable. In the meantime, she saw neurology for her headaches, and then they did an MRI, which looked okay. She saw GI for her nausea, which felt it was related to her constipation. Next, please. So then I'm really concerned at this point. This girl is really going blind. How can I help her? Should I repeat pulse steroids? Should I give her more oral steroids? Maybe immunomodulatory therapy, or maybe consider some more testing? I'm not sure at this point. Next, please. So then I'm thinking, am I missing something? Her vitritis does look better, but her vision doesn't look better. If it was Muse, wouldn't it have improved in like 6 weeks? Or maybe she had it before that. But her appearance looks like so bilateral, symmetric, though it's like wreath-like pattern. It lacks that distinct hyperfluorescent appearance that we notice on Muse. So then I decide maybe I should check her retinal function with an ERG. So then I send her for ERG to Dr. Fulton. Next, please. And then the ERG showed her A and B wave amplitudes were very low with delayed implicit time, delayed dark adaptation. This was in both photopic condition. And then this confirmed that she had rod cone dystrophy in both her eyes. But at this point, we still didn't know what her dystrophy was. So we did send the genetic testing, and then we got the report in about 3 months, which confirmed she was compound heterozygous for 2 pathogenic variants of ABCA4 gene, which confirmed a diagnosis of Stargardt's or probably some kind of ABCA-apathy, given that it was such an unusual presentation for her. Next, please. So as we know, Stargardt's is autosomal recessive juvenile onset macular dystrophy. The way we remember is the pisciform flex, the fish-like flex, which she didn't have, bullseye maculopathy, which she didn't have. Next, please. So in kids, about 35% of the patients, they don't have the classic fundus abnormalities that we relate to Stargardt's disease, causing for a delay in diagnosis. Some of these kids are treated for amblyopia, uveitis, functional vision loss. And then studies have shown that some of these kids take about 3 years to get to the correct diagnosis, to even 2 years, even before they are considered for their ERG testing. Next, please. So I think for her, she presented with more vitritis than we would typically like. And then being a uveitis specialist, we always think in that direction, but then probably there were some red flags right from the beginning. She had that bilateral symmetric appearance, color vision deficiency, that look of the macula with disorganized RPE. And she did have that dark choroid or the silent choroid that's classic in 80% of the patient with Stargardt's, which was probably missed with all that uveitis picture. Even her chief complaint, probably now when I look back, I feel it was related to the dystrophy. Next, please. And then some other conditions I want to make you aware about, which I think Stephanie already enumerated, which can present in a similar way. They include RP, Leber's, Conrod dystrophies, CRB1 related retinal dystrophies, and then congenital night blindness. So always think about other conditions if it doesn't present in a classic way, doesn't respond to your treatment. Great, thank you so much.
All right.
Hi, thank you for having me. So I'm Masquerade, I'm Peds and Neuro-Op, so I'm going to be talking about bilateral retinal exudates as it codes. Next. These are my current financial interests. Next. So the case is that of a healthy 5-year-old girl that was sent for abnormal fundoscopic findings in the left eye. Basically, 6 weeks prior to presenting to us, she had a fever of unknown origin that lasted for 14 days. It was evaluated by infectious diseases, tested for influenza, COVID, viral respiratory PCR, rapid strep, Bartonella, IgM, and IgG, all negative. She had some elevated inflammatory markers, and everything self-resolved with no treatment within 14 days. 2 weeks later, her left eye was noted to drift out. And then 2 weeks after that, she complained of blurred vision and pain behind her left eye. She saw an optometrist who noticed a left bilateral decreased vision, left worse than right, with a left RAPD. The left nerve is swollen with some exudates in the macula and around the nerve. So they sent her to pediatric retina. Next. So on presentation to pediatric retina, she continued to report fuzzy vision in the left eye. The eye pain had resolved. She had no other symptoms, no headaches in particular. Her vision on the right was 20/40, left was 2300 with a persistent left RAPD. Color vision was decreased on the left, and she had anterior vitreous cells. Next. So this is her fundus photo, and you can see her nerve to be pale and elevated with some gliosis around it. There's exudates around the nerve. There's exudates in the retinal periphery, and there's some exudates in the macula. So the question was, is this Coates disease? Next. So an OCT was taken, and it showed some subretinal fluid, outer retinal changes, and partial thinning of the inner retinal layers. Next. The right eye was normal. And when they showed me the OCT, is this Coates or is this neuroretinitis? We got an OCT from a patient with Coates, and what was really striking is that the Coates patient has a completely normal ganglion cell layer versus our patient has a very attenuated ganglion cell layer. Next. So this led to the diagnosis that this is probably a neuroretinitis. So a little addition to the history, she adopted a straight tip in 8 to 9 weeks prior to presentation, so about 2 weeks before the fever. Next. So we sent her record to the uveitis team, what this could be. They were like, well, Bartonella is most likely. It's atypical for toxoplasma and toxoplasma. Sarcoid could be, and also could be idiopathic, and consider other causes of infection. So we embarked on a whole bunch of workup. We got an MRI first, and this is an MRI of the orbit. So I'm showing the fat suppressed contrasted cuts. And there's no obvious enhancement of the optic nerves. Next. On the coronal cuts, the neuroradiologist called no enhancement, but next. But I thought there was some enhancement of the left optic nerve. But the trick I used next to tell if the nerve is enhancing or not is I decrease the contrast on the brain. And if I cannot see the nerve, then whatever I'm seeing on the previous cut wasn't there. Next. So other workup to obtain, would you repeat Bartonella? Would you do other testing? So we did all other testing next. And there was a whole bunch of them. All of them were very reassuring. Next. And we did repeat Bartonella, which was actually highly positive. Next. So the question at this point is with repeat, and my favorite paper for treatment of Bartonella is this paper that was published in 2012 in ophthalmology. It was retrospective, but it was multi-center, and they compared the outcome of those who took antibiotics versus not, and there was no difference in the final visual outcome. So I don't necessarily treat Bartonella. Next. So her final outcome, she had a vision of 20/20 and 22/50 with a synchrostroma in the left eye and the left RAPD. We did patch partially, which didn't improve her vision, but it improved her optic. And her left optic nerve ended up being pale with gliosis with pseudo-MGH2 flying of the retina. Next. So another case I want to show you just for typical example is a 3-year-old who adopted another kitten, came in with a vision of 20/70 and 21/25 with a left RAPD, had a febrile illness about 4 weeks prior. Next. And we thought there was bilateral optic nerve head swelling with macular stars. We got an MRI, same thing on the MRI. So this is the contrast enhanced coronal cuts with fat suppression. Yes.
Dr. Eldari, would you be, it sounds like there's a little bit of background noise. Would you be able to maybe, or we're getting, it's a little more garbled now. It was good in the beginning. I don't know if there's something you can adjust.
I only have one speaker on my computer.
That's perfect. Whatever you're doing right now is perfect.
All right. Okay. So if you decrease the contrast on the MRI, you can see next. You can see that there is still some enhancement of the optic nerve. So this was called as an active optic neuritis. Next, we obtained a lumbar puncture on this patient, which showed a CSF that was bland. Next. And so workup was done as an inpatient because the presentation was more acute. And given enhancement of the intracranial portion of the optic nerve, we obtained a lumbar puncture. And given that he was given a course of steroids for presumed active autoimmune optic neuritis with a neuroretinitis component. I think it's my wavelength. I'm going to turn off my video. So Bartonella IgG was positive. It took us 3 days to get the results of the Bartonella IgG, and we also treated with azithromycin and rifampin at the recommendation of infectious diseases. Next. So the question was, do we regret giving steroids? Given that the lumbar puncture was bland, I do not regret giving steroids. Next. And the final vision was 2040 and 2050 with 4 out of 4 color plates, and there was mild optic nerve head pallor. Next. So my fellow comes up with the question that he wanted to get rid of his wife's cat after seeing 2 kids still lose a lot of vision from kittens. So we got this from the CDC website, that the cats become infected with the Bartonella from bites of infected fleas or contact with infected blood. So cats involved in a fight or outdoors cats or adopted cats who have not been seen by vet. Next. So in conclusion, Coats disease is a retinopathy. The optic nerve early on and pre-treatment is not involved, and we should not see RAPD or optic atrophy. And neuroretinitis requires neuroimaging. If there's active enhancement of the retrobulbar optic nerve, further workup and treatment are advised. Thank you.
I'm
That was
going to
great.
stop sharing there, and I'll let
Yeah.
you share the next one, Dr. Davidson.
Yes, I'm going to try again, but be prepared in case it doesn't work out. And then the next section is Maze and myself talking about uveitis and papilledema. So if there's any trouble with the audio, please people speak up also, so we can everyone can see screens and hear us would be important. I've got the slides up. Let me make sure I'm sharing my screen. Share screen and slideshow.
Looking good.
Okay. The only thing is, tell me what I'm supposed to do with this black thing. Are you guys seeing this black thing? Where do you put it so it doesn't block the
Everything looks good. We can see the whole screen perfectly.
Great. Okay. So Dr. Eldari and I are going to have a conversation about some cases and with uveitis and some swollen nerves and decide what needs to be done. So do all these patients need a neurological workup if they have optic nerve swelling and they also have uveitis? So first I'm going to present a case of a 7-year-old boy who had 1-week history of headache, vomiting, and photophobia. His parents took him to the ER where they told him he had a viral illness and sent him home. But when he wasn't getting better, the family brought him back to the emergency room, but came to Children's Hospital. Children's Hospital ER, pardon? Children's Hospital ER sent him over to ophthalmology for an exam where we saw that his vision was good. He had 1+ injection in each eye, 2 to 3+ cell, and what we termed grade 2 papilledema. Here were his nerves.
All right, sorry, I had to switch audio to my phone. Can you hear me now?
Yes, I can hear you.
That sounds great.
So these nerves are obviously swollen, and when I like to grade the optic nerves, I go with the Frisson scale, and I have a simplified version of the Frisson scale. So I like to go with the vessel obscuration. So if we look at these optic nerves, we can tell that some of the smaller vessels are obscured. So this is a grade 3 or higher optic nerve. So that's moderate to severe.
So in looking at those nerves and thinking of this patient, all his symptoms, does this patient need a neuro workup? We here was an OCT. Go ahead.
So before we even looked at the optic nerve, this is a child coming in with headache and vomiting along with optic nerve head swelling. So whether the case is a uveitis or not, you already know that we need a workup for this patient. So this is a nice OCT of the macula.
So yes, he needed an MRI and an LP. He'd already had those before he was even sent to ophthalmology. His opening pressure was elevated. He had white blood cells in his CSF, but he had no normal protein and glucose. He was deemed to have a viral-induced uveitic meningitis syndrome. He was treated with oral steroids. He unfortunately developed pancreatitis, which was felt to be due to the oral steroids, and then we switched him to Humira. We treated him with Humira for 6 months and then discontinued them. His optic nerve edema went away completely. His uveitis has not recurred, and it's been 2 years since his presentation. Here are his RNFLs pre and post treatment. If there's anything you want to say about that, Dr. Eldari.
So yeah, the OCT of the RNFL is a really nice tool to tell progression of edema, and sometimes it's better than the fundus photos because unless you jump grades on the fundus photos, you really can't tell that the RNFL improved. So this is a beautiful example of resolution of the edema.
So I think in the take-home point about this patient is that there was both uveitis and meningitis causing the optic nerve edema, but the systemic treatment of the primary cause of the inflammation treated both, and he did not need additional ICP lowering medications or procedures. The next case is a 5-year-old boy who has a long history of Crohn's disease, something that was very early onset. It's its own entity, apparently, VEO-IBD, very early onset IBD. He had come to the emergency room, though, with symptoms of uveitis, including unilateral eye redness, pain, and light sensitivity for 4 days. He was seen by us, and his vision was good, 20/20 in each eye. He had 1+ injection on the right and 1+ cell. He was looked at with a portable slit lamp, so maybe the cell was even greater, but it was graded as 1+ cell and in the right eye and rare in the left. And he was deemed to have grade 2 optic nerve swelling. I don't have any photos to show at this point, but at this point, does this patient need a neurological workup? What would be your thoughts at this point, Dr. Eldari?
So there's a systemic disease that we know can be associated with other problems. So with an IBD, I would like to know if he's anemic. I'd like to know if he has kidney disease or other systemic involvement. Anemia and high blood pressure and kidney disease in particular are red flags for me for intracranial hypertension, papilledema, and increased risk of vision loss from papilledema.
So in terms of whether we thought this child needed a workup, I guess it depended who you asked. The resident and fellow who were on call, this child came in on a weekend where they weren't immediately seen by an attending. They were concerned that the amount of optic nerve edema was greater than what they would expect for the amount of uveitis that was present. And they had already planned to admit the patient to neurology for an MRI and an LP. When I had heard about the patient, I thought, well, gosh, why did they need all this? They have uveitis, they have optic nerve swelling. Can't we just treat the uveitis and see what happens to the optic nerve swelling? But the horse was out of the barn, and neurology wanted to go ahead with all of their treatments. And so he did have an MRI, he did have an LP. The opening pressure was a little elevated. He was sedated, so maybe it wasn't as high as it seems when you see it as 32. But his normal, his CSF analysis was normal. And this is his MRI. Dr. Eldari wants to make any comments.
So this is a nice MRI of the orbits, and we can see that, I don't know if I can point to it. I'm gonna try to use a laser
I've got my
pointer.
arrow.
You can see, yeah, so go
I've
to
got
the
my
tip
arrow.
of the optic nerve. You can see that tip of the optic nerve. You can see a little bit of enhancement at the tip of the optic nerve. And I don't see frank flattening of the posterior poles, but if you go to the coronal cuts, you see that target sign whereby the sheath is more swollen than the nerve. So these are two of the signs that are consistent with increased intracranial pressure.
And as you mentioned, considering whether he has anemia, you alluded that this could be present based on his diagnosis. He does have chronic anemia. His hemoglobin was 8.3 at presentation. His treatment involved topical steroids, plus we quickly put him on a TNF inhibitor that would be good for his IBD and his uveitis. He never needed treatment with Diamox. His uveitis and optic nerve swelling resolved. Ultimately, though, he is on a Janus kinase inhibitor, which is another class of medicines that is showing some effectiveness for uveitis treatment. Maybe it's a future webinar, but that is what this child is on. So, you know, he did have increased pressure. He did have increased intracranial pressure and uveitis, but he didn't need separate treatment for the increased intracranial pressure. Just the treatment of the systemic disease treated both. So, you know, what would have happened if we hadn't done the MRI and the LP? I don't know. Do you have any thoughts about that, Dr.?
If you treated the primary disorder, you would have treated the anemia and the cause of the papilledema and the uveitis. So probably the edema was caused by a combination of both papilledema and the uveitis, and treating the primary systemic disease managed both of them. And I don't think, yeah, so I agree with you, like getting the lumbar puncture and the MRI and the lumbar puncture on this child would have been a soft call, because there's another obvious thing you could have treated and you would have had the same outcome.
Thank you. Next case is an 11-year-old girl who had anterior uveitis that was chronic, that had been ongoing for 8 months. It was managed topically by the referring IMD, but because she could not taper below twice a day pred, she was referred for further management. She had 20/20 vision and 20/25 in the left. She'd had no KP, but fine endothelial dusting, 3+ cell bilaterally, and her nerves were swollen as well. We have pictures.
So yeah, so these are quite swollen. You can see here the vessels disappear and then reappear. So that's vessel obscuration. And one of them is a large vessel. So that's at least a grade 4. Same thing on the left eye. So that's a high grade swelling. You definitely need to do a workup.
So does this patient need a workup? Here are her OCTs, if you want to make any comments about that.
So this is an OCT of the retinal nerve fiber layer, and this has been corrected. So a lot of times when you get an OCT on a severely swollen optic nerve, it's all over the place. So don't just look at the number. And we can see that the retinal nerve fiber layer is quite thickened. I don't even need to look at the number. Even, let's say we didn't have the luxury of a fundus photo, you can actually see that there's vessel obscuration on the infrared shots. I always like to look at a macular scan in a setting of a uveitis because I'm looking for outer retinal changes to see if there's a posterior component to it.
Thank you. Additionally, she was old enough to participate in a visual field, which was abnormal. And so we did get we did do a neurological workup. Her MRI was normal. Her opening pressure was elevated, but the fluid analysis was otherwise normal. And here are her images.
So this is the non-contrast scan, but we can see on the coronal cuts, there is that similar target sign that we saw before. And you can see here the eyeball, instead of being round, it's a little flat. It's a little ellipsoid in shape with the back of the eye being flattened. So that's flattening of the posterior pole, another sign of increased intracranial pressure.
So she was treated with oral steroids and also Diamox. Eventually she required TNF inhibitor Humira to help her uveitis and help her taper off steroids. And she's also been using Diamox for 10 months, but her optic nerves the swelling has completely resolved, and her uveitis is under good control. So, you know, it doesn't sound like in this case that the visual field prompted you to get the neurological workup, but what if you have a patient who is too young for visual fields, and just what your comments are? You know, oftentimes when we are examining children and we're noting that they have optic nerve swelling, it's not through a fundus photograph, it's not through an OCT. We'd get a quick flash and we're like, oh, that's a swollen nerve. How do we navigate that? How do we make that decision of whether this child needs a neurological workup when we don't have that imaging?
So if we don't have any imaging at all, or at least we have OCT.
So you got to work really hard to get an OCT is your answer.
I would get something, especially if you only got one look. So let's say you're in the emergency room, you don't have any access to any imaging. What I go by is, do you see any vessel obscuration? Do you see any pallor of the nerve? If there aren't any, I think you're okay to wait. But the way I wait is I try to get photos and I see them and I watch them very closely. And as long as they're not going into grade 3 and they're improving over time, I'm okay waiting. If you only had access to OCT, you can do visual fields. One trick I use, which works if the problem has been there for at least a few weeks, is that I get a ganglion cell map on the macula. And if that's normal, that usually tells me that the optic nerve, that the visual fields are going to be normal. So if you cannot get any other testing other than an OCT, the OCT will tell you multiple things. So first, the red-free image on the OCT will tell you if there's vessel obscuration. Second, the ganglion cell map will tell you if there's visual field loss. And third, it's a very good baseline that you can follow over time to make sure that they're improving as you're treating your uveitis.
Thank you. This is now your case that you wanted to discuss.
Okay, so I'm going to present this case. So this is a 17-year-old girl who's referred from the uveitis clinic for workup of a bilateral optic disc edema. 3 months prior to presentation, she had a pink eye starting on the right and on the left, and symptoms resolved within a day, so she was never evaluated. A month later, she has a pink eye again. She took some eye drops from urgent care. Again, it resolved. And then 2 months after that, she sees an ophthalmologist who diagnosed her with inflammation and started her on Pred Forte every 2 hours and atropine. Next. So her past medical history includes anxiety, depression, migraine, exercise-induced asthma, and she has cellulitis and paronychia of her left foot at the age of 14. And other than recent weight loss after starting fluoxetine, and some anxiety, her review of system has been fine. And these are her medications. The eye drops she's taking include atropine and Pred Forte. And she's not on any medication that increases intracranial pressure. And her social history was non-revealing, and her family history includes Hashimoto's thyroiditis. Next. Her labs were negative for ANA, RF, ANCA, syphilis, TB, Lyme, beta-2 microglobulin, HLA-B27. Her platelets were slightly elevated, and her white blood cells were normal. And on exam, she was 20/20 with normal color vision. Pupils showed no RAPD. She had pretty extensive anterior uveitis and with some anterior vitreous cells with no small snowballs. Next. And here are fundus photos. So I'm sorry, I only had AAPOS, but you can see that there's blurring of the disc margins nasally on the right more than on the left. Next. And here is her red-free OCT. So you can follow all of these vessels and none of them is obscured. Next. Her retinal nerve fiber layer was 145 and 126, so elevated for age. Next. And her OCT of the macula showed no outer retinal changes. Next. And this is her OCT of the optic nerve itself. And another sign I look for is upward bowing of Brooks membrane. If it is, so right now it's bowed downward. If it's bowed upwards, it's more concerning for a retrobulbar pathology. Next. And these are her visual fields. So we can see some generalized depression. You can see the total deviation map is a little, has some depressions on it, but the pattern deviation is fine. So this is explained by her uveitis. So what would be your plan? For me, given the absence of headaches and visual field deficits, we elected watchful observation to see the effects of uveitis treatment. The patient was seen again in 2 weeks, 4 weeks, and 3 months, and the nerve swelling was improving as uveitis was improving. The visual field remained intact, and there was no neuroimaging obtained. Next. So there's a checklist whenever I see a swollen nerve in the setting of uveitis. There's the dangerous scenario whereby we have an independent cause for optic disc edema from an optic neuritis, retrobulbar pathology, or from elevated intracranial pressure. And there is the common scenario, which becomes a diagnosis of exclusion. So we need to make sure we go through the checklist. So the checklist is the grade of edema is less than 2. So the Frisson scale, if you look at it, it's quite complicated to remember. Basically, grade 1 is nasal elevation of the nerve. Grade 2 is 360 degrees blurring of the disc margins. Grade 3 is when you have small vessel obscuration. Grade 4 is large vessel obscuration, and grade 5 is obscuration at the disc itself. You really can't tell where the disc is anymore. So my rule is follow the vessels. If you can see the vessels all throughout, you're grade 2 or less. If you cannot see the vessels all throughout, you're grade 3 or less. The Frisson scale was based on a fundus photos and not the exam, and therefore, when you're looking in 3D, you can underestimate grade 3 in particular. So fundus photo helps. The other criteria is that the vision might be decreased from the uveitis itself, but we should not have a visual field loss that's not explained by a retina change. There shouldn't be a color vision abnormality. There shouldn't be an RAPD. There shouldn't be a headache other than what's referred from the eye. And close follow-up shows improvement in the optic disc edema as the uveitis is being treated. And in conclusion, the optic disc edema can be secondary to uveitis. Given that an optic neuropathy is a potentially dangerous scenario, workup is recommended if there are any signs of an independent optic nerve dysfunction. And with that, we say thank you.
I think we probably have some time for questions. Jenny, have any been coming in that we should try to address?
So as I was talking, somebody asked about the Frisson scale, and Ginny sent a very good reference for the Frisson grades.
Here, there are a couple questions here. How slowly do you expect optic nerve edema by Frisson scale to go away after treatment?
So it depends on the grade you're starting off at. And so for me, it's not complete resolution. What we care about is evidence of improvement. And there was evidence of improvement within 2 weeks. But for it to completely go away, for the case with the mild edema, she took a good couple of months.
And then we did have a question regarding the optic nerve and Bartonella case. Is optic nerve edema from cross-reactivity of Bartonella or an infectious infiltrative process?
That's a very good question. So there's multiple papers, theories about that. What's commonly accepted right now is that the edema and the inflammation and even the enhancement is secondary to an inflammation that was caused by the Bartonella itself, but not direct infection. And that's why if there is no fever and no evidence of an acute infection, it's debatable whether or not you want to give antibiotics.
Great. I think that's, we've got another one coming in. Is a biopsy mandatory in a typical JXG? That's a good question. I guess that would be me here. I would say it's helpful, but I would probably, you want to?
Yeah, I think in the dermatology world it is. I think that when the dermatologists see what looks to them to be JXG, they biopsy a lesion and get a histopathological diagnosis. I do think it is mandatory.
Thank you.
Yeah.
I had a case, I'll just say that was a recurrent hyphema case where on UBM you could see the thickening of the iris, and I sent it to Carol Shields and she didn't biopsy it. She said it was classic enough by presentation and responded to steroids and went away. So I do have one that didn't get biopsied, but she had no skin lesions to access whatsoever.
And she didn't do a fine needle aspiration of anything in the iris?
I don't think she did.
Oh, okay. So she gets to make that decision. Okay. Yep.
I think the question was, well, whether the skin, I mean, it's one thing to do a skin biopsy. It's another thing to do a biopsy, an intraocular biopsy of something. It seems like the skin biopsy would be pretty easy
Right.
to confirm a diagnosis and make but there's probably gray shades to everything.
Yeah. Okay. So I will move on. If there aren't any other questions, I will move on to the next section. If I can make it work again. Here's hoping. Let me
got
share
this.
my screen. I got this. I got this. Let me share my screen. Okay, let's get to the slideshow. Please, where is it? Okay, and show. Why is this not working? Okay, we're gonna go to this one, slideshow. Okay, we got it. So next section is discussion with myself and Dr. LaMattina about a class of medications called checkpoint inhibitors. Checkpoint inhibitors are increasingly used to treat a variety of both malignant and benign tumors. And the first ones that were used in medicine were used to treat melanoma, ipilimumab, which targets CTLA4, and nivolumab, which targets PD-1. I'm going to share a couple cases with you. First is a 15-year-old boy who had metastatic melanoma. He had a scalp lesion that which had been resected, but then developed metastases, and he was currently on immunotherapy with those medicines, ipilimumab and nivolumab. He presented with bilateral eye redness and light sensitivity. On our exam, his vision was slightly reduced at 20/40 and 20/60 in each eye. He had 2+ cell. He had some fine KP. There was no vitritis. He did have some mild blurring of his optic nerves, indicating a little edema. There's a question if he had a macular star or if that was just striae. Apologize for these blurred images, but they show that there was some mild edema of his nerve fiber layer. We treated him topically with Pred Forte, which provided good control of his uveitis, and he continued to receive his checkpoint inhibitors. The next case is a 12-year-old boy also with metastatic melanoma. His original lesion was in his left ear canal. He was on nivolumab like the last patient, but he was also receiving a treatment called TVEC, talimogene laherpestic oncolytic virus, which essentially is a herpes vector that is getting injected directly into his melanoma lesions. He had metastases to his pleura, so he was getting this medicine directly into his lung lining. And within 1 week of his second injection, he began to notice additional hearing loss and significantly blurred vision, as well as eye redness. He came to the emergency room where ENT put him on prednisone 40 milligrams because of the hearing loss. And then he was referred to ophthalmology. So when we were examining him, he was on 40 milligrams of pred. His vision was significantly reduced to 21/25 in the right and 21/50 in the left. He had blepharitis and a lot of PEE. He had 1+ cell in each eye, and it was very difficult to get a good view of the back, but you could tell his nerve looked swollen. Here's his attempts at OCT imaging, which was just very blurry. He was put on topical steroids in addition to the oral prednisone, but in discussion with oncology, they were very concerned about him being on oral steroids because they decreased the efficacy of his checkpoint inhibitors. So we, from an ophthalmology standpoint, agreed to do some subtenon's Kenalog as an alternative. When he was getting sedated for his TVEC therapy, we did the subtenon's Kenalog. Sadly, he developed cataracts very quickly. This is one of his eyes. His vision was reduced to hand motion in the left eye, 2100 in the right eye. He couldn't hear because he'd lost hearing in one ear from the original melanoma lesion. And then his hearing, he had an autoimmune hearing loss in his opposite eye because of the immunotherapy. We did what we could to help him in his situation since he was functionally blind and deaf. He even had a cochlear implant and cataract extraction. But in the end, I think he did have some improvement of his vision and hearing in the end, but he passed away. But just for a little bit more information on these checkpoint inhibitors, we're going to now turn to Dr. LaMattina.
Before I get into this, I'd just like to thank Stephanie. You are doing an awesome job. This has been a really great panel to be a part of.
Sort of. Thank
a
you.
year and a half in, we all still are familiar. You can always have these technical difficulties with all of this technology. So thank you so much for inviting me to be a part of it. So, you know, one of the big initial questions is, aren't chemo drugs one of the mainstays of our treatment for uveitis? Absolutely. Methotrexate, which you know we all know is used as a major chemotherapeutic agent, is our first line agent for kids with uveitis, chronic non-infectious uveitis. And so we do use these drugs, but there are certain ones that we know are associated with uveitis. The ones we'll talk about a little bit more in depth today are checkpoint inhibitors and then our BRAF and MEK inhibitors. Next slide. At risk of putting you to sleep on this Sunday morning, I am going to do a little bit of pathophysiology review, and that's just because sort of understanding the mechanisms of these drugs can help us to understand sort of why they're used for chemotherapy and also why they may cause uveitis. So when we think about checkpoint inhibitors, our T cells, as they're going around our body, have these extracellular proteins that are interacting with the extracellular proteins on our own cells. Some of the proteins on our cells stimulate that system, as you can see here. This sort of illustrates that point. Some of these proteins are gonna say go, versus our checkpoints are going to say stop. It's going to say, nope, I'm a normal cell, I'm a healthy cell, please don't attack me. And that's important in our body and our body's function. What is tricky is that cancer cells have evolved this evasive mechanism where they mimic these checkpoints. And so they're basically saying to the T cell, oh no, I'm a normal cell, when in fact, as we know, they aren't. And so checkpoint inhibitors are basically designed to inhibit that protein so they can't have that interaction. So when the T cell comes up against the antigen from that cancer cell, it says, oh, this is abnormal. I'm going to go ahead and stimulate the immune system to attack these cells without having that checkpoint say, no, 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 please don't attack me. Next slide. And so this was actually, these drugs were super, super important. We used to, see these stage 4 metastatic melanoma in particular patients just didn't have a lot of options, didn't respond really well to therapy. And these checkpoint inhibitors were a game changer for sending them into remission. It was really pretty miraculous how this came about. And it's only been in the last 10 years. James Allison, to illustrate that point, was the one who conceptualized this idea and won the Nobel Prize for it, shared the Nobel Prize for it. And so ipilimumab was the first one that was approved. And a lot of these drugs are initially approved for the use in metastatic melanoma. And it was only approved in 2011. So it took us some time before we really started seeing these uveitis manifestations. Next slide. So we do now have several different checkpoints that we target. There's the PD-1 inhibitors, the CTLA-4 inhibitors, and then the PD-L1 inhibitors. Next slide. As I said, they all kind of started in terms of being used for metastatic melanoma for the most part, but have evolved and now have lots and lots of other indications with which we use them for. Next slide. So when we talk about the uveitis, we have 1% to 3% of patients who have some form of ocular adverse events, with probably less than 1% really developing uveitis. The onset for these patients is anywhere from 1 to 104 weeks after initiation, with a median time of about 2 to 4 months that we really are seeing most of these uveitis presentations. The most common presentation we see is actually non-granulomatous anterior uveitis. Obviously, we have much more concerning severe manifestations, with panuveitis being the most severe that we see. Next slide. This slide is basically just to illustrate that we have 6 drugs now that are checkpoint inhibitors that have been known to and described to having caused uveitis. One of those drugs actually isn't FDA approved in the US, but is used in other parts of the world, and that they really can have a very wide variety of presentations, anterior, intermediate, posterior, and panuveitis, with the most severe and the one that I think at least brought these drugs to my attention 4 or 5 years ago is this VKH-like presentation. Next slide. We do have two other checkpoint inhibitors that have been more recently approved. They don't have uveitis data yet, but as I said, with ipilimumab, it was really a couple of years before we started seeing more of these case reports with ipilimumab-induced uveitis, and that was the first approved. Next slide. So I just want to illustrate some of the variety of presentations. This was, and we don't actually have a lot of case reports of these, and I'm encouraging Dr. Davidson to publish them because there's not as much data in pediatrics as we have in adults. So this was a 54-year-old patient who basically developed this sunset glow-like appearance after having a VKH-like presentation. And you can see on FA had some staining where there was resolution of the prior subretinal fluid, a case that was reported when this patient was on ipilimumab for metastatic melanoma. Next slide. We also can see these sort of multifocal choroiditis-like presentations where you can see these yellowish white choroidal lesions scattered throughout the retina bilaterally in our fundus photos, and then notably on ICG you can see those choroidal lesions as well. Next slide. There's also been keratitis described with these medications. This is a patient who is on nivolumab for melanoma who developed an ulcerative keratitis picture. Next slide. And so when we think about who gets uveitis, the data is going to be skewed because most of these drugs are used for melanoma. So it's not surprising that metastatic or meta-analyses show that melanoma is associated with uveitis. More patients are on it, so that's probably a bit of a skewed sample. The other thing that we see is patients who are on combo therapy. So a lot of patients who are like Dr. Davidson's patient who are on nivolumab or on ipilimumab together are more prone to getting uveitis. And these tend to be used in conjunction, mostly in melanoma cases as well as renal cell carcinoma. Next slide. So what do we do when this kid, or in our case, and this kid comes in with uveitis? Do we stop the medication? Not necessarily. So several years ago, when we were first seeing these case reports, what ended up happening, we were at the AUS winter meeting, I remember really vividly. So it felt like everybody had a case of checkpoint inhibitor induced uveitis that they were presenting. And what ended up happening in a lot of the cases that were being presented was the oncologist stopped the drug. And while that was sort of understandable, they want these patients to have good quality of life, these are potentially life-saving medication. And as Stephanie illustrated, we are able to treat these uveitis, particularly if it's a more mild anterior uveitis, as is most common, locally. We don't necessarily need to stop the drug. So 92% are able to achieve control of their inflammation without stopping these checkpoint inhibitors. Often we'll use topical for those anterior uveitis. As Stephanie mentioned, oral steroids, while they're great for those more severe VKH-like presentations, are great, they may affect the efficacy of our checkpoint inhibitors. So often we're going to use local steroids. The interesting thing to think about here is periocular, these subtenons injections work great, but we also have really good safety data on Ozurdex in kids. They are gonna likely go on to develop a cataract. So you may have to contend with that down the line, but that's another option for treatment for these patients. Next slide.
So thank you. That was a great discussion. I have one more case of a patient who was a 5-year-old boy. He has a complex history of Rosai-Dorfman as well as Langerhans cell histiocytosis. He was noted to have BRAF mutant disease. It extended into his bone marrow, liver, lymph nodes, and he was treated with different medications that were targeted for MEK and BRAF inhibition. The BRAF inhibitor was called dabrafenib, and the MEK inhibitor was trametinib. He came to us knowing that these medicines could cause ocular side effects, so we had a baseline eye exam, and that was normal. And then COVID happened. He was started on the medicines, and he wasn't seen for 10 months, but eventually came back because his eyes were red. On exam, his vision was 20/50 in the right eye and 20/25 in the left. He had 2+ injection bilaterally. He had band keratopathy, so signs of chronicity. He had fine KP, 3+ cell. He had a posterior synechiae in the right eye, and his optic nerves looked a little swollen. Here are his OCTs, again, indicating some optic nerve edema on the right worse than the left. In addition to him presenting with the uveitis this way, he also had some systemic problems. He had hypercalcemia, hepatosplenomegaly, and lymphadenopathy. The team was concerned that he was having a sarcoid-induced drug reaction, and so they decided to stop the MEK and BRAF inhibitors in this case. We treated him with oral steroids, and ultimately they did want him to go back on some therapies, and he was started on just one of the inhibitors, the trametinib, and coupled it with methotrexate and 6-mercaptopurine. He was able to successfully taper off all his steroids, and his uveitis has not recurred. So what can you tell us about these, Casey?
Yeah, so these drugs have a slightly different mechanism of action. So rather than being sort of that extracellular protein, BRAF and MEK proteins are intracellular. And essentially what they do is they're part of that pathway to stimulate cell growth. And so when these proteins are, kind of out of control, you end up having increased cell growth, and that leads to cancer. And so this is, again, not to get you too overwhelmed, that's the gist of these physiology slides. It's just showing that they're involved in these cell signaling pathways and that it is different from our previous drugs. Next slide. So as we were speaking about some of the drugs earlier, the BRAF inhibitors are really vemurafenib and dabrafenib that are involved with that we see with uveitis, and then for MEK inhibitors, the trametinib is really the main drug. These are, again, primarily used for melanoma, although there have been reports of these drugs being used for astrocytic or for pilocytic astrocytomas as well. Next slide. So when we think about the uveitis for these patients, they actually have a slightly higher incidence of uveitis than our checkpoint inhibitors, with about 11.8% developing uveitis. And it's similarly to our checkpoint inhibitors, they can really do it all. They can cause anterior uveitis, intermediate uveitis, posterior uveitis, and a VKH-like picture. So this was an example of an adult patient who had the vitiligo in addition to these big exudative detachments related to their treatment. Next slide. And so the last thing I just want to point out, so all of the principles that we spoke about for checkpoint inhibitors in terms of what to do for treatment, in terms of how we approach these patients, are going to be the same. So, and oftentimes we find that we end up hearing sometimes from oncology colleagues, checkpoint inhibitors, and maybe they're talking about the BRAF and MEK, and maybe they're talking about the checkpoint. So sometimes these umbrella terms can get a little bit confusing. So I'd say the take-home point from that standpoint is, if you have a child who's being treated for chemotherapy who gets uveitis, the first question is, what is the drug? And I don't expect you to remember all of the different names we've talked about here. Pop it into PubMed and see if there's uveitis presentation associated with it, because I know this can all be really, really overwhelming. There's always new drugs coming out. It's hard to keep up with. But the last kind of point to make is that it's not just uveitis that we see with these medications. So similarly, if you have a patient who comes to you with a Graves-like presentation or a myasthenia-like presentation, a cranial nerve palsy, these are kids, if they're getting treatment, that review of systems is so important, because if they're getting treatment for cancer, this may be related to their drug. And so that'll affect our treatment plan. So keep that in mind with any of these kinds of presentations as well. I think that's all I've got for you.
Thank you. Thank you. That was excellent discussion. I don't know if there's any questions we want to answer. Actually, Jenny, why don't you do this part and then we'll stop and do questions.
Sounds good. That was great. And I like how you summarized it at the end, kind of put it in PubMed, see if there's an association, and just, I think there were a lot of great points in that talk. So COVID-19, questions your patients with uveitis may ask. So as you know, we sometimes see our patients more often than the rheumatologist does, just because their uveitis is more active. And so they may be asking you kind of, what should they be doing? And so a question I've gotten a lot of is, does COVID-19 infection or vaccination lead to a flare of uveitis? And I think it's really, really important to any infection can be a trigger, or any vaccination can be a trigger of something that's already been primed to happen, someone that's at high risk. You have strep throat, and you'll have a patient that will get a uveitis recurrence, even a common cold. So I'd say that COVID-19 is certainly not a cause, but yes, in some patients it might trigger it, but think of it like any other type of infectious or vaccine trigger. There's no data to support a direct cause. And the goal is to avoid COVID-19 infection and transmission. And right now, vaccination's kind of our way to do that. Go ahead and advance, please. And so what are the rheumatologists advising patients about the COVID-19 vaccine? Get the vaccine. The risks of the disease and sequela outweigh risk of vaccination. And also to encourage vaccination of family members and close contacts, as that has been shown in certain series to be protective of especially those who can't be vaccinated yet. And a multi-dose vaccine is recommended over a single-dose vaccine. So the Pfizer for 12 and older, Pfizer or Moderna greater than 18 years. And I guess I shouldn't have called this a booster. Infectious disease clarified this. It's a 3-series vaccine. An additional dose is recommended 28 days after the 2-dose mRNA vaccines for those who are immunocompromised, just because they do not get the same robust response from the first two, so that is something that I'm seeing my patients getting right now. Go ahead and advance, please. And then another question that I've gotten as the ophthalmologist is whether the immunologic medications need to be held. And in general, if the disease is well controlled, some medications may be held, but there's a list of medications of ones you hold, ones you don't, and that's something that to ask the rheumatologist. But I would say, that regardless of where they are in the disease process, as long as the rheumatologist agrees, the vaccination should proceed as quickly as we can. All right.
Thank you. The one thing I would add in terms of specific medicines, I know that our rheumatologist is telling patients that when they get the vaccine, they should specifically hold methotrexate for the week that they get the vaccine, to allow their body to develop the proper antibody response to the vaccine. So, and methotrexate stays in your system for a good 2 to 3 months. So holding 1 week's dose isn't going to risk a flare too much. So that's what they're recommending in relation to the vaccine.
And I would say that that's something also where every rheumatologist I've talked to is a little bit different in that, because that's the recommendation from the ACR, but it's based on flu vaccines and it's being extrapolated. And so it's very much a patient by patient decision. A patient who's sort of teetering on the edge of control, we're probably not going to hold the methotrexate in, versus a patient who has been quiet for 1.5 years already on their methotrexate. You may feel more comfortable holding that dose.
Yeah, I think our rheumatologist at Boston Children's, they also discontinue methotrexate for a week before they get the vaccination. Yeah.
It's actually, I think the recommendation is for the week after because for my adult patients, if they're well controlled and I manage their methotrexate, I hold it for the week after again. And there's some pediatric rheumatologists I know who continue it, and some who are kind of following those guidelines, and most will kind of say, what do you think in terms of their uveitis control? Is it okay to hold or not?
Yeah, that's right. Yeah, so I think most of our patients, they take it over the weekend, right? So then they get their vaccine during the week, and then they don't take a dose, and then they go after that. So you're right, absolutely. Yeah.
So I think that's the end of our planned content. Obviously we were going to do some questions. I do think we have some time. I want to ask whether Dr. Stahl, would you want to go back to your talk in any way, since it was a little bit disjointed because of my technical difficulties, and review anything else?
It's up to you guys, but I mean, I feel like, just putting it out for awareness and seeing the pictures of how it's different. I feel like we covered it, but I'm happy to talk more if anybody wants me to.
I don't know if anybody out there in the in the viewing land would like that, let us know. And same with Dr. Eldari, if we wanted her to review your mimicker case, your Coates disease versus neuroretinitis, because some of the audio was a little bit hard to hear, if we would want that to be repeated. Anybody in the Outland, but meanwhile, Jenny, why don't we go to some questions?
So I don't have any in the queue here.
Okay.
But I think something that we all ask is when we get back to the Bartonella case, is if we get a positive IgG, do we treat? Do we just treat it as inflammatory? And what's the evidence? So if anybody wants to comment on that.
Sorry, I missed the question. Somebody was texting me.
That's fine. No, I asked, we're always wondering, if you get a positive IgG for Bartonella, who do you treat? Who do you just treat with steroids? What's your threshold? And treating in terms of antibiotics, antimicrobials.
So IgG or IgM?
IgG, or if you have, would that change your management if you had a, recent exposure of IgM positivity?
I think I would be more inclined to treat if the IgM is positive. If the IgG is positive and I don't have the patient doesn't have any fevers or any signs of an active infection, I usually don't treat, but I will refer everybody to infectious diseases and work with them.
There were a couple questions that came up, I think, in your talk, Maze, that I wanted to talk about a little bit, actually, which one of them was, would you repeat the Bartonella testing? And my rule of thumb in uveitis is if I have clinical suspicion for something, I'm going to repeat a test for it, just for my own peace of mind. If I have really high clinical suspicion for an infectious etiology, and the testing was initially negative, so I'm glad that came up in your talk, that in your case, that the patient had repeat testing that what did show it was elevated. The second thing question you had posed in that case was, do we regret, or one of your cases, do we regret starting the steroids? And the piece I would say to that is that I think there are some infections that we all know, the like scary infections where if you add steroids, they go downhill very, very quickly. And the proof was in the pudding in your case that the patient did fine, even though they were on steroids for a few days before they started the antibiotics. And so I think it was okay, but TB, for example, is one that's a slower infection. And I remember learning in fellowship that there will be times in India where they're overwhelmed with TB and they're trying to get patients into IV, where the ophthalmologist may actually start the oral steroids before they're able to start their TB therapy. And it's because it's not a viral infection. It's not something that you're going to send off a cliff if you start oral steroids. So those would be the 2 points I'd make about that case.
So in our case, we didn't actually give the steroids until we had a bland lumbar puncture. So yeah, I'm a little nitpicky about that, because didn't present to me early on, but I've seen someone who started with HSV that started in the orbit, was given steroids before a lumbar puncture and went into ARN.
Oh yeah, I wouldn't do it. I was saying a viral thing is something I would absolutely not give oral steroids for. I absolutely agree with you on that.
In a place with enough resources, I think we are bound to do our due diligence before treating with something that can cause harm.
Agree. And I personally would never start steroids before RIPE therapy in a TB patient as well. Just making the point that because of the negative tests and initially, right? Because I think that was if I'm remembering the case right, there was a negative test and so steroid just started and then the test was positive. Maybe I'm mistaken of the case, the order of which things happened in the case, but that's just I would say that generally, yeah, I completely agree. I don't start oral steroids before we have negative infectious workup, but that the reason I think that case did okay in spite of the later positive testing was reassuring, to say the least.
Okay, I lost audio for a little bit, so I think I agree with you. Somebody's asking why an MRI was ordered in a neuroretinitis case. So I know a lot of people do not order MRIs in neuroretinitis. In kids in particular, I do. And the reason I do is, especially if the vision loss is recent, the reason I do is because we've reported that MOG can present with a neuroretinitis, and you really don't want to miss MOG because it can be associated with an encephalitis, and that one does require treatment with steroids. So I've been getting MRIs on my pediatric neuroretinitis case and on the adults who are bilateral.
I don't see any. I see a question about JIA uveitis screening that I answered in the text, but just to emphasize, screening is a patient that JIA screening is a patient that's never had uveitis. They and they actually should be screened into adulthood on a yearly basis. At least that's what the recommendations that are coming out soon recommend. Once a patient's had uveitis, they're kind of a lifer, and their follow-up will be determined based on how active their disease is. Also, probably lifelong follow-up, but depending on how well their disease is controlled. And then a good question here on how much JIA uveitis do you tolerate before needing escalation of therapy? Some kids have rare cell chronically. Thoughts from the panel?
We talk about these things all the time, so I think most of us are kind of on the same page. I think the preference is that we don't have any cell in these eyes. But if it comes to, we talk about the classic less than 5 cells per high powered field, and if you've done everything you can, or if they're on no medicines and doing fine with no secondary complications, I think there's certain cases that we all tolerate just a little bit of cell.
Agreed.
Yep, agreed too.
I usually ask about infectious triggers. Did you have a cold recently? Did you have strep throat recently? Because that might change, that you may see a little blip in your very controlled disease from a recent infection. But you want to follow that patient closely to make sure that that resolves.
Right. If I see some rare trace cell, I might see them back in a couple weeks and just make sure it's not increasing. And if it's staying at that same low level, then I'll just continue to monitor. But, where are they on a curve? Are they increasing? Is it stable that way?
So there was one more question that came up. It says, it's for Maze. If you have a patient with a classic clinical picture for cat scratch, including recent adoption of a stray kitten, initial Bartonella, IgG, IgM negative, repeat labs in a month also negative, but full resolution of optic disc edema and negative review of systems, would you be willing to keep this diagnosis?
Yes, because sometimes you have different strains of Bartonella. We typically only test for Henseley, but you can have other strains as well. There have been case reports of some being caused by strains caused by a horse or by other animals as well. So yes, I would keep this diagnosis. However, the only thing I would do differently is in a kid who's had a cat scratch and the optic nerve edema resolved, I'll see them once in 6 months or a year and then not follow them over time. This one I would follow a little bit longer because I don't have a diagnosis. And I would make sure I got MOG on them.
I have a question. Maze, do you think you could walk us through the OCT of the macula and exactly what you look at when you're evaluating the optic nerve?
Yeah.
Let me pull up. Do you want to pull it up, Maze, or do you want me to pull up?
Pull up an OCT of a macula. Let me try to find one.
And just how you analyze it, because it went by fast, and I want that I think that's something that I get OCTs of the macula. I look at the NFOS, but specifically looking at the ganglion cell layer in your evaluation, I think that was a critical point.
Okay, can you pull it up for me? Pull up a macular map, one of your macular images.
Yep, I'm trying to go back to which talk, the one of our talk. It's not immediately present for some reason. I don't know why they disappear.
Okay, I'll go in the box.
While they're pulling that up, one point for potential future discussion is there's evolving data about looking at anterior segment OCT and identifying cells. So I think it'll be interesting to see cases like Aaron's when that technology evolves and grows, that we may actually find different characteristics on imaging of retinoblastoma cells versus our leukocytes actually on imaging. So something that may be interesting future directions.
Okay, it's not a perfect projection, but can you see?
Yes.
Yes.
Okay. So sometimes we don't have the luxury of a macular map, and all we get is a one-line scan through the macula. So what I go by is first I identify the inner nuclear layer, because that's the one that's almost always constant unless you have macular edema. Once I identify the inner nuclear layer, I can look and see where the ganglion cell layer is, and I expect the ganglion cell layer to be at least the thickness of the inner nuclear layer, if not a little bit thicker. So that will tell me if there is optic atrophy or not. And then after I look at that, I look at the outer nuclear layer. And it also has to be the same thickness, and you have at least the same thickness, if not like 1.5 times. And you have that differentiation of the central photoreceptors that give you the foveal vision. And then I look at the EZ and make sure it's intact. Then I get the macular map that Spectralis gives you. And if I can't pull up Spectralis right now to show it, but if you have access to the machine itself on Heidelberg, you can actually right click and segment it and get a map of every single one of the layers to compare them. So I can look at the whole macular map and see if there's a deficiency. So sometimes if you have a kid with a homonymous visual field loss, you will see actually a homonymous thinning of the macula. The other thing, like if you have a Cirrus machine, they will give you the ganglion cell layer on the spot. You don't have to actually segment to get it. And that's it for a normal one.
Thank you.
Yeah. All right. Well, thank you, everybody. I don't know if there are no more questions. I really appreciate everybody's time. Thank you again for being here on a Sunday. Thank you for so I apologize for my technical difficulties, but hopefully it was still educational and worthwhile. Thank
you. I found another talk about optic neuropathies in children. I have more OCTs on there. If you want, I can pull it, or we can just say thank you and bye.
I'm happy to still look at them. I mean, we were supposed to go till 12. We thought we were going to go over, and we've somehow had extra time.
Yeah, we spoke too fast.
So optional, but hey, I'm here. I'd love to see them.
All right, so here we go. I'll share again. So. So this was given a few weeks ago at another conference. Can you see my screen, or are you seeing the Zoom one?
It says Zoom United.
Okay. Better?
Yes.
Perfect.
Okay, so, here's one about papilledema grades, since someone asked. And so this is someone who came in with venous sinus thrombosis. So look at this nerve. This is a grade 2. You have 360 degrees swelling of the optic nerve. And on this one, you can see there's some flame-shaped hemorrhages and vessel obscuration. So 360 is the grade 2. Vessel obscuration is grade 3. As it got worse, you started having large vessel obscuration. So you can see this vessel disappears and then it reappears. So that makes it into grade 4. That's another grade 4. And grade 5 is when you start having vessel obscuration at the disc itself. So this is an example for it. And this is a girl with a Chiari. This is a nerve which there was a question whether or not we were suspecting pseudopapilledema versus true papilledema. And grade 2 and lower can look exactly like pseudopapilledema. Up until now, there's not a very good modality to tell them apart. So you can see 360 degrees elevation and blurring of the disc margins, but no vessel obscuration. And this one just nasal. So that's a grade 1, that's a grade 2. Eventually, this girl ended up having both problems. She had both edrusen and papilledema. And this was the scan I was telling you about for upward bowing of Bruch's membrane, which would be indicative of a retrobulbar pathology. So if you remember, I showed you the other picture. The Bruch membrane was bowed downwards. This one is bowed upwards. So this is more upwards than this one. This is the macular scan. So again, on the macular scan, I'm going to try to get a laser light. Here's the INL, and here's the GCL. So the nuclear bands are dark, and the connector bands are light. So find the INL and compare everything to the INL. And everything should be a little thicker than the INL. Sometimes you'll get something like this here, how you see the shaggy photoreceptors. That's just the way the light is inclined, so incident to the light. But overall, the map is okay. Now this got stuck. And this is the ganglion cell map after we segment it. So it'll give you this nice map that is symmetrical. And usually in kids, the number is higher than 1.05 on the spectralis. And I think it's very similar in cirrus. So this is a kid who was complaining of decreased vision. And basically, this is a kid with spina bifida who had a shunt and complained of decreased vision and was thought to be functional. So this is the appearance of the optic nerve, which wasn't impressive to be swollen. We got an OCT of the RNFL, which was fine, except for the temporal quadrant was a little thin, which, you know, depending on the positioning, racial variations, that could be okay. So with an average retinal nerve fiber layer of 99, this was considered normal. But then when we pull the OCT of the macula, you see the INL, and then you don't see a ganglion cell layer. It's extremely thin. So this nerve was swollen on top of atrophy, and it got missed. Can you tell? Okay. So eventually she actually had dilation of the third ventricle that caused the compressive optic neuropathy on top of the optic nerve edema. This is another type. Oh, this was thought to be morning glory nerve. And then we got the scan through the optic nerve, and we didn't see the colobomatous excavation of the optic nerve. So this ended up being Bergsmeister's papilla. This was an optic nerve hypoplasia. This was tilted optic nerve pseudopapilledema. Actually, this was also a form of optic nerve hypoplasia. So when I'm looking at the optic nerve, I also measure the Bruch's membrane opening. It's supposed to be above 1,000 or 1,100. This girl had a very small one and eventually got the diagnosis of optic nerve hypoplasia, although the nerve looked swollen, did not look hypoplastic. I can't remember what this case is. So acute decreased vision, the nerves look swollen. There was a central scotoma on visual fields. I think that was an LH2N case. And same thing. So you had the RNFL looked swollen to thick. So normal in one eye and thickened in the other eye. and the eye that looked normal, you see attenuation of the ganglion cell layer here. So that would have been a clue that this was swelling on top of atrophy.
How do you know that it's, I mean, to me, that ganglion cell layer looks thicker than the internuclear layer.
So this one does. So you see so it's the dark band. So you see the dark band of the INL, and it is a dark band for the GCL. It's not as dark. It's not as obviously dark, but when you zoom in, it's actually quite dark. But if you look here, the IPL, GCL, and NFL are almost fused together. There's a sliver of a GCL, but that's it that I can see.
Okay.
All right.
Thank you.
I had more, I think. Yeah, that's it. That's the colobomatous excavation that you can see on the OCT. Okay, I'll give everybody a break.
No, this is fascinating. This is great. We don't see OCTs with all this pathology. It's amazing. Thank you so much.
Sure, you're welcome.
Yeah, thank you for walking us through that.
Sure, maybe we can do an OCT one on another day.
Yes, it's
That'd be
definitely
awesome.
an idea for another webinar. All right. Well, thank you very much, everybody. I really appreciate your hard work putting this together. It was really great. Appreciate it.
Thank you. Thank you for having me.
Ooh, is there a source that covers OCT abnormalities? That's one last question.
So our department made a book called Handheld of OCT in Pediatric Retina and Optic Nerve. It's a really nice book. I have no financial interest. I did write 14 chapters in there.
Wow.
They're very short chapters. They're like one-page chapters.
Emmy Hartnett also has a really nice pediatric retina textbook that has a lot of case examples too.
Yeah, that's a really nice book.
All right. Thank you very much. Thank you.
Thank you. Bye.
All right,
Have a good
thank you.
Sunday.